Welcome back to the Band-Aid Man OC, your source for all things EMT, EMR, and sports medicine. I'm your guy, Eric Johnson, aka the Band-Aid Man himself, and today we're going to be going over lifting and moving patients safely. Now, before I get started, I want to make this abundantly clear. This is certainly going to be something that is more applied to EMT and EMR, but the methods that we're talking about here can also be very easily applied to what we do in sports medicine. So I want my sports medicine students, if you are watching, to pay close attention to the techniques and the devices that we have in EMS, because many of these devices are available with your sports teams and with your athletic training staff. So this isn't just going to be for EMT or EMR. This does span all of the areas of education that I currently cover. So for those of you that are in EMT and EMR, this is going to be Chapter 3 in the Emergency Care Textbook, 13th edition. So be sure to follow along. And if you're using my PowerPoint in Canvas, just make a quick note that my PowerPoints in these recordings will look different than what you have access to. So don't freak out too much if it looks a little bit different. Finally, if you are not in any of my classes and you're simply watching, this is a very quick disclaimer. I am not teaching you how to appropriately and safely lift without the benefit of watching you do it. So if you go and do any of these moves and you end up hurting yourself or hurting your patient, this is my disclaimer. I'm not telling you how to do this. I'm simply introducing it. So I will not take any liability for you coming back and saying, oh man, my back is completely smoked because I watched your video and now I have this degenerative disc disease 10 years down the line or whatever the case may be. I'm not taking any liability for that, but in today's day and age, it's important to, make those quick notations before we get started. But without much further ado, Chapter 3, Lifting and Moving Patients. In EMS, we are constantly being tasked with getting patients from A to B. If you think about it, our entire job is getting patients from where they were when they were hurt or became sick and getting them to what we like to call definitive care, the kind of care that will end up allowing them to eventually get better. We don't have very many tools in our box, our ambulance, our airway bag or drug box or whatever the case may be to definitively fix things and say, okay, you're good to go, have a good life. So we need to really prioritize which patients need to go immediately, which ones need to stay, and we can do a little bit of treatment. But eventually, for the vast majority of our patients, unless they sign out an AMA or they are able to drive themselves or have a family member drive them, we're going to be taking them. And that's where we need to figure out how to get them on the gurney, how to get them into the ambulance, how to get them safely to the hospital. So today we're going to be talking about two very specific topics. Number one, first and foremost, is protecting yourself. The body mechanics that go into lifting a patient is very, very important. Our patients can range in any size and weight capacity, and we may be dealing with a pediatric or infant patient that weighs 10 to 30 or 40 pounds, and we may be dealing with someone from our older group of patients that may be considered medically obese or morbidly obese, and we can be dealing with patients that are in excess of 200, 300, 400, 500 pounds, you name it. Now, I don't want to get too far into depth on what you could potentially see out there, but many of you have seen television shows like My 600-Pound Life or things of that nature. So we know that the human body can be unbelievably heavy for certain patient demographics. And, I want to make this real clear. I'm not casting any kind of stone their way. Everyone has their own specific body type and everyone has their own battle. That is a discussion for a totally different video, probably a totally different channel. But today we need to take into consideration the fact that some of our patients may be extremely heavy, and regardless of their weight, all patients can cause us to injure ourselves, and we could potentially injure them if we are not analyzing, learning, and employing proper body technique and body mechanics. Now, aside from body mechanics, we want to make sure that you are very comfortable and confident with the different types of variations that we have to move our patients around. We have three very specific types of moves that we'll be going over today, but I'll brush over them real quick. Emergency moves, urgent moves, and non-urgent moves. The vast majority of our moves are going to be non-emergent, followed by urgent, or the faster we work, the better our patient's chances of survival and eventual recovery will be. And finally, our least common emergency moves. These are the types of moves that we reserve solely for I am going to get hurt or killed, and my patient will too if we don't immediately vacate the area. These are the least common because it is not that often that we find ourselves in situations where if we stay where we are risking the lives of ourselves, our partners and crew, and our patient. Now, like I said, we're going to start with body mechanics. This is going to be a review for many students. Most of my students, which I teach full-time, are at an age where they've been briefed on body mechanics. Many of them are athletes, so this shouldn't be anything new. But for those of you that don't necessarily have that background, or you don't really feel like you've ever been taught how to use proper body mechanics, well, we're going to break all that down. Body mechanics really comes down to using your body in the most appropriate and effective way so that we avoid injury and make sure that we can effectively lift and move our patients. Body mechanics should always be considered before we go into moving a patient. If we're not confident that we can safely move the patient, we may need to get a different piece of equipment. We may need to take a moment to reconfigure the way that we're going to move them, or we may need to get additional personnel. And this is the concept of the lift assist. The lift assist means that we have additional personnel that respond out to our call to make sure that we can safely move and position our patient. So first and foremost, we need to consider the weight. If the weight of the patient appears to be heavier than what you can lift, you should always consider a lift assist, or at the very least, getting other individuals that are not part of our agency. So if you're responding to a 911 call, we very rarely, but occasionally may ask members of the public to assist. Or if we're in a healthcare facility, we may ask the discharging nurse or other healthcare professionals in the building to assist us with moving them. The best way to determine if you and your partner will be able to effectively lift and safely transfer the patient from their current location, whether that be the ground, a chair, a bed, or anything else, is to do what we like to call a test lift. We like to do just a quick test to make sure that if they're on a sheet, that sheet will hold. That if we're extending ourselves in any certain direction, that we're A, not going to hurt ourselves, and B, we're not going to be in a position where we could potentially drop the patient, because that's really going to end up being a bad day for all parties involved. Next, we need to consider our own limitations. What are limitations? Am I hurt? Am I out of shape? Am I too short or too awkwardly positioned to go ahead and reach across the bed? Am I too tall compared to the relative height of my partner? These are all things that you'll learn more when we start working in my classroom in person, and when you go off after EMT school and you join a company or an agency. These are very common techniques to determine if an individual that's been hired is going to be able to effectively do the job, and it will also introduce you to the way that the agency, the company, wants you to get your patients from point A to point B. A being where they were, B being either your gurney or their final destination. And finally, communication. Communication is absolutely key. If you and your partner are not actively working together, you will be pulling or pushing the patient at the wrong time. You may be lifting while they are not prepared. It's as simple as saying, okay, so we'll lift on 3, 1, 2, 3. If we've done this with a test lift, then we already know when they're going to lift. And if we've already said we're going to lift on 3, we probably shouldn't lift on 1 or 2. So these are very common things that you end up learning very directly, but having the introduction before we even get started by moving patients around is a great way for us to start getting our minds prepared for the concept of, I need to move humans. I need to move things that are ultimately more fragile than any plates or dishware that we have, more fragile than any of the electronics we may be moving around. These are lives. These are other humans. We don't want to drop them. So communication is key. Now, when we are lifting a patient, we need to remember the rules. These are 4 very simple rules. Position your feet properly. Your feet should be no wider than the width of your shoulders. So your feet should be at about the same width as your shoulders. We always lift with our legs and not with our back. Lift with your legs, not with your back. Next, we never turn or twist while we are lifting. The lift should be up, across, and down. We should never turn or twist. And finally, we don't want to compensate when lifting with one hand. What does that mean? Lifting with one hand and compensating means that we're pulling or pushing on another object that's not our patient. Truly, we should not be lifting with one hand ever. We should always be using both of our hands in the same way that when we're lifting and using proper lifting technique, that both of our feet are flat on the ground and positioned in a way that they will not slip or need to be repositioned. Also, these are some very important points. Keep the weight as close to the center of your body as possible. This means trying to keep the weight from being extended across an object or out of the reach of the individual that is lifting. If you are reaching across a bed, or if you are extended outwards, you are working and utilizing more muscle than is necessary, and you're putting undue and additional strain on your lower back. Those of you that are already EMTs, my skills instructors especially, are probably laughing because you're thinking, well, we do that all the time. There are ways around that, folks. We don't need to extend our backs to the point where we end up having to do some type of lumbar surgery 10 years into our career. There are better ways to lift. But I'm also a realist. We are going to be working with individuals that don't necessarily have this type of training. This isn't advanced training. This is a part of your normal curriculum. But in my class, you will learn how to appropriately and effectively move patients in a way that doesn't put you, your partner, or your patient in danger. And finally, if we're going to be transversing any type of stairwell, we should not be carrying our patients using the GS or Georgia Street method, the fireman carry, over the shoulder, side by side, things like that, unless our patient is on a cervical spinal board or a backboard. We want to use our stair chair as often as possible. And we'll talk more about stair chairs in just a little bit. Now, what you can see here is an example of a stair chair, which, as I said, we will discuss in just a bit, but this is an appropriate way for us to effectively manage moving a patient up and down stairs. We have a 3-person crew. 2 of the individuals on this crew are effectively managing the front and rear of the stair chair, and a 3rd member is spotting the individual that is walking backwards. Now, before we go any further in my class, we're going to be talking about why having this type of communication and coordination is important, and we're also going to be talking about why their positioning on the stairwell is important. But I want to put this out to all of my viewers. If you have a patient that is in any kind of a device and you are manipulating a stairwell or other uneven surface, they will feel very uncomfortable. It's not that uncommon. If you get them close enough to some type of rail or object, they will instinctively reach out and try to grab the rail, which will eventually cause them to slip and fall. It will also cause you to slip and fall. So we want to try to educate our patients as well as basically mitigate the risk. So we want to try to get them away from these walls as much as possible. We want to try to get them away from anything that they could reach out and grab, and constantly reminding them, we have you, we've got you, please don't reach out. And at this point, you may need to be a bit more forceful. I am not an advocate of yelling at your patient, but you may need to raise your voice and say, do not touch the rail. Don't touch that. You will make yourself fall. We will drop you if you do that again. Cross your arms across your chest. Do not grab the rail. Now, there's almost no reason to ever raise your voice at your patient. This is one of those immediate dangers to you and your patient that need to be addressed aggressively, loudly, and immediately. So don't be afraid to raise your voice a bit, but you don't need to scream at them like a drill sergeant. Don't you touch that rail right there. We're all going to fall down. Not necessary. Loud and direct is all you need to be. When we're dealing with any kind of material, we want to have a grip. Not just a grip, but a power grip. We want to make sure that our hands are fully wrapped around the device, whether it be our gurney, our backboard, our breakaway flat, our scoop, our any device that we're trying to manipulate. We want to make sure that we have a firm grasp around the majority, if not the entirety, of that device. Our gurneys are made in such a way that you should always be able to get a power grip around it, regardless of the size of your hands. It's just not big enough that you can't get your hands and fingers all the way around. Also, we want you to emphasize the use of what we call power lifting. For those of you that spend your time in the gym, you already know what this is. Flat or nearly flat back with your chest kind of puffed out and your rear end, your butt, basically put into a position where it looks like you are like you're trying to show off the lines of your belt or whatever the case may be. What we're trying to get you to do is understand that proper lifting technique is not going to make you look cool, but it'll save your back and save your career. So I talk a lot about that in my class. I'll be putting up some videos on proper lifting technique, but I always tell my trainees, if you feel like you look like a total dork while you're lifting, you're probably doing it closer to correct than not. If you feel like you're picking up your patient going, yeah, I just totally, got them all the way up, then you are probably not doing it correctly. So very, very important to remember that proper lifting technique will rarely, if ever, make you feel like you are the coolest person on the street at that moment. When we're reaching, we also want to make sure that we keep our back in a locked in position. This means that we're not overextending in either direction. We don't want to be flexed backwards, and we definitely don't want to make the cardinal mistake of reaching too far forward. We also, as we've said before, want to avoid twisting when reaching, and we also want to minimize the reach to no more than 20 inches in front of the body. Finally, we want to avoid prolonged reaching when we are doing some type of lifting maneuver. So if you're constantly looking to readjust or if your partner isn't quite ready, go ahead and put yourself in a relaxed position until you're ready to conduct and execute that move. Also, when we're pushing or pulling, we want to try to emphasize pushing rather than pulling, if at all possible. Still, keep that back locked in. Keep that center of gravity right there in your gut, right in your belly button, and try to pull through that line. And finally, keep the weight as close to your body as possible. We also want to make sure that the weight is, as often as possible, below the waist or at the waist. We don't want it to be too low, so we're looking for about waist height, but we definitely don't want to go below the knees if possible. And in the other side, we don't want to go up so high that we are above the umbilicus or the belly button. Well, again, continue to avoid pushing or pulling, and we want to make sure that your elbows are bent and your arms are close to your sides. When our arms are straight down, we're already putting our patient below where we would like to move them, which would be below your knees for most of you. Also, it can cause undue stress on the elbow joints as well as the tendons and ligaments that are going to be covering the muscles and bones that you are effectively manipulating throughout the move. Now that we've talked about proper lifting technique and best lifting mechanics, we need to understand what the difference is between these three types of moves: emergency, urgent, and non-urgent. Like I said before, non-urgent is going to be the one that we use most often, followed by urgent, which is less often, but certainly a part of our usual, at least monthly, if not weekly or daily type of moves, depending on where you're working. And finally, the least common, emergency. This is when you or your partner or your patient are about to lose your lives because staying where you are is no longer safe. Your scene has rapidly devolved, and now it is unsafe. Some situations for emergency moves. The scene is hazardous. You have oil or some type of flammable material that is leaking out of a vehicle that is on fire. You have some type of uncontrolled roadway where people are driving by at a high rate of speed or are not yielding to your emergency vehicle. You have a vehicle that may not be fully locked in place or is teetering on the ledge of going over the side. We may have a life-threatening condition that requires repositioning, and repositioning speaks specifically to the ability to manage the airway. So we have a patient that is in a cramped position, or is in a position where their airway is closed or no longer visible. So it may be that their neck is impinged. It may be that they are in a closed quarter situation or a closed quarter situation, or they may be in the prone position where they are face down on the ground and we can't visualize their airway. Some other situations that may require emergency moves. Constantly changing scene safety, some type of danger to you, your patient, or your partner, whether it be violence, civil unrest, or some other type of uncontrollable scenario. And of course, we have rapidly changing or unpredictable weather patterns. So if we have a situation where we are dealing with a patient in the vicinity of a fire, a flood, some other type of major wind or weather event, we need to make sure that they're in a safe position. Emergency moves really are going to be reserved for that. And of course, we may need to perform an emergency move if our patient is on, if an individual is on top of another patient that's more critical, or if we can't get a full scope of the severity of the injuries of another person. Emergency moves are not done very often. These are the types of moves that we do once, maybe twice every other year. We only do a handful in a career, so they're not very common. If we're conducting an emergency move, something has changed in our scene size up that would make the scene unsafe, or we did not do an effective job of surveying the scene and determining that it was no longer safe. So emergency moves, these are the most uncommon moves that we will end up doing. Some examples of emergency moves. The clothing drag. You can see that the provider here has their hands on the shirt of the patient themselves. So what they're going to do is they're going to grab the material and they're going to pull. The incline drag. We always want to make sure that our patient goes head down first, because if you drag them by their feet, they're basically just going to walk away with a significant amount of injury to their brain and to their body. I would much rather sacrifice their heels and maybe their lower legs than their head. And of course, we want to protect the brain and the vital organs more so than we do the lower extremities. I know that I'm laughing and it seems like an obvious thing, but the patient that needs to be moved in an emergency situation is certainly going to be in a position where they can't help. And you may be in a position where you're thinking faster than your brain can process. So by training you to understand that these emergency moves need to be done in a certain way will help you remember, oh, don't drag them by their ankles. That's not going to help. The firefighter drag. We can take the patient's arms and we can slowly approach the exit with the patient basically being dragged by their wrists and upper arms, with us being the locomotive or the vehicle that gets them from A to B. This is very uncommon, and the reason that we call it the firefighter drag is because we're keeping the patient at the lowest position possible while also staying in a low position. This is effective if you are in a smoky environment, but honestly, if you're an EMT and you're in a smoky environment and you're using this, something has gone horribly, horribly wrong. There are very few other scenarios in which this would be appropriate unless it was some type of situation where you had a confined space and this was the only move that worked. But it is important to show you that these are the kinds of things that we can do. Now, before we go forward, these emergency moves, again, are not going to be done very often, and they're going to be used only for patients that are going to lose their life or in a scenario where we will lose our life and we want to get our patient out with us. Another emergency move that is more common is known as the blanket drag. By placing the patient on some type of a blanket or other device, we can pull them out of the situation or location that they're in. This is going to be more often used than the firefighter drag, and this is something that we can use our own blankets for, or the type of blankets that we may find in the home. But I want to make a quick note. If you're dragging them a long distance, or if you're using a blanket that is not yours, that may fail. So it's important to understand and remember that material really is something that we need to constantly reassess. because there's no worse feeling than, oh man, I'm just killing it. I'm getting them. And then you look back and the blanket is in tatters and your patient is 20 yards behind you because you weren't paying attention. So you have to remember that friction is definitely a consideration here. These emergency moves may not be the most appropriate depending on the location or the geography of where you are. We wouldn't want to use this, on gravel or on hard packed ground. We would only really want to use this inside of a home or in a situation where they had to go a very short distance, because once the material is gone, we have to go back to other methods like the clothing drag or the firefighter drag or the incline carry. We also have the one rescuer assist. Now, as someone that has worked in event medicine for a very long time, I can tell you that the one rescuer assist is the one that most people are familiar with. You got their arm around the back of your neck and across your shoulders, and you've got your hand on their wrist and your other hand placed directly on their waist, and you are helping them walk. This is known as walking assist as well. However, if your patient is able to move like this and we have two rescuers, we should have one person on either side. Why, Eric? Why do we want to have one person on either side? It's simple, nobody. The reason we want to have a person on either side is to reduce or eliminate the possibility that the patient will lose consciousness rapidly and become too heavy or encumbered to be supported upright by that one person. We're trying to go ahead and hedge our bets. If a patient needs to be assisted like this, there's a potential that they could lose consciousness. There's a potential that they are not able to effectively keep themselves upright, and they've already made that abundantly clear. So if we have the personnel, we want to make sure that we utilize both people, both partners, you and your partner, to get them into a safe position where we can effectively assess and treat them. Remember, these are emergency moves. These are emergency moves. We're not going to be using these on patients that are not critical or are in a place where the scene is considered safe. Here it is, the penultimate. This is the way we want to move our patients, to rescue or assist. The only time that you'll really ever want to utilize that one rescue or assist is if your partner is taking care of yet another patient that is in need of assistance and can't effectively walk on their own. Normally, if the scene is secured and safe, we can take the time to slowly move our patients one by one using the two rescue or assist. If the patient can be assisted and the location where we are is not conducive to effective patient assessment. What are some of those examples? The scene itself is too loud. The scene itself is rapidly evolving and we don't feel like the scene is secure. Or if we're trying to get the patient from wherever they are to our ambulance or to a different location to preserve their privacy. So that would be some of the times that we would use the two rescue or assist in a non-emergency fashion. Urgent moves, unlike emergency moves, will be used if the patient requires treatment that can only be done after we move the patient. This would be if the patient is in some type of a confined space, if we need to have a lot of room to work under the circumstances of emergency childbirth, or we need to do some type of splinting, or if the scene itself is causing our patient to decline further. These would be scenarios where we have a patient that is experiencing a heat or cold related emergency and we want to remove them from the environment because it is making them worse, or because the patient is in some type of a state where they are having a psychiatric emergency. Removing them from the scene can be the best way for us to effectively treat what's going on, because many of our patients are experiencing some type of psychiatric emergency that has everything to do with the fact that they are being overstimulated and have no ability to effectively moderate their response to the environment, which is a big way to say we're trying to control the environment because at the end of the day, we have the ultimate form of control. We have our ambulance, our working office, our rolling emergency room where we can move the patient. Now, another style of urgent move that we need to talk about is a patient that we have concerns may have a compromised spinal column, or they may have some type of injury to their neck or back. Now, we're going to go more in depth on this, but we do a lot of discussion in my class about spinal motion restriction, the concept of spinal motion restriction, or SMR. We also talk a lot about the complications of not really having enough information about what happened to your patient. EMS, just like any kind of medicine, is constantly evolving, but there is a very weird aspect that we are just clinging to, which is the concept of spinal immobilization using rigid, non-conforming backboards. We, for a very long time, used to put patients on these rigid, non-conforming backboards because we were concerned about them having a spinal injury, and the thinking was, well, if they have an injury to their spine, we really want to make sure that we immobilize them so that they don't induce any further injury, that we don't cause a patient to incur more severe or new injury. But the thinking and the practice were very different. If you know about the human spine, you know that it's not flat and rigid. That's not how it works. And when you put somebody on a flat and rigid surface, it's the same as sitting in an upright position on a chair with no padding for any period of time. Eventually, you will become uncomfortable regardless, because that is not the way that humans are meant to be positioned. In addition to causing undue pain and undue suffering, we can also cause other issues. We can cause the patient to incur new injuries. We can even cause them to become hemodynamically unstable. We can cause their blood pressure to go up or possibly go down in a negative way. Same thing with their pulse, even with their breathing patterns and respiratory effort. So backboards are something that we have evolved in the last 5 to 10 years of thinking of being the penultimate way to protect the spine, and more now of a device that we can use for a couple of different scenarios, but really not for long-term patient transport. We can use them to move patients around that we suspect or have a high suspicion of a spinal injury. We can also use them as rigid surfaces for chest compressions, and they're very effective at getting patients through small areas. If you've ever done any kind of moving, you know that sometimes you have to manipulate the furniture to fit through the door. Well, in some of these places where you'll be working, you may need to get your patient through the door, and the backboard, your patient's not going to fit through the door laying on their back under any circumstances. So we basically use them as patient movers. But as a local fire department once said, and I really like the way that they say it, they're only going on a backboard if they're flying or dying. And for the most part, backboard use has been de-emphasized with the emphasis really being on stabilization and restriction of movement of the cervical spine, which is what the vertebrae that make up the components of our neck. So we're not as concerned at restricting motion elsewhere. We do want to encourage our patients not to move, but we will be restricting motion through a device, through a cervical collar or C-collar, but the rest we're going to just remind them, hey, don't move, don't try to turn to talk, and we'll move you using our own devices. Now, we will go into that more in depth when we get into trauma later on in the semester, later on in the year, but it's important to remember that backboards still remain on our ambulances. We still use them on a regular basis. So when we are performing an urgent move, especially if we're going to use a backboard, we want to use the log roll maneuver, where we have multiple providers that are placing their hands on different places on the patient and rolling them at the same time, so that we don't cause any undue stress to the spinal column itself. We don't want it to move independently. As you all know, our bones are able to move independent of one another. We don't want the spine to move at a different rate or at a different location than the rest. Now, the urgency of the log roll may be determined after we've done the log roll, especially if our patient is complaining of back pain and we think, oh, it's just back pain, and then we go and we log roll them and we observe the back and we see, oh, snap, they got a bullet hole in their back. That's why their back hurts so bad. That may change the urgency. But because a log roll is almost always used for some type of traumatic injury or traumatic mechanism, we want to always consider that move may go from non-urgent to urgent, but we normally put the log roll in the urgent move category. Also, understanding that urgent moves are not going to be because our patient is crashing, but because our patient needs to get into the back of the ambulance so we can better assess them or control the environment. We want to remember that urgent and emergency are different. An urgent move doesn't mean that our patient is going to die immediately or that we are in any danger. We are simply we're trying to emphasize that staying on scene for a long period of time is not going to benefit the patient. It's probably going to hurt them. So ultimately, an urgent move should result in you getting them from where they are into the back of your ambulance. It doesn't mean that if we're doing one of these urgent moves that they have to go to the back of the ambulance, but you need to use that complex part of your brain that makes critical decisions. Many parts of EMS, especially when we leave the BLS realm, the basic life support realm, and move into ALS, which is the next step as an advanced EMT or as a paramedic, you make a lot of critical decisions. You need to make a lot of decisions that are not clearly black and white. They're very gray. As an EMT, you'll learn that much of your job will be very set straightforward, will be very black and white, but we do start to introduce these concepts of gray, of not having the right or wrong answer immediately presented in front of you. You need to take everything into consideration and then make your determination of what's best for your patient. Also, urgent moves get us into the concept of a rapid extrication. The rapid extrication means the longer our patient stays where they are, whether it be in a confined space, in a vehicle after a traffic collision, or in some type of space where we can't effectively do our work, that they will start to decline in a way that will negatively impact their recovery or overall survival. So we have other tools such as our Kendrick's extrication device, or KED, and our shortboard to very quickly immobilize them, and by use of the appropriate procedure of putting all of this equipment in place, allow us to effectively remove them from that space, whether it be using multiple individuals, using the pull strap right behind the head, or in some very extreme cases, a high angle or low angle rescue system that will be deployed by our fire department personnel. Once the patient is fully extricated from that area, we'll remove the KED, we'll remove the shortboard, and we will either use a long spine board or we'll go ahead and employ our spinal motion restriction protocol, or SMR. Now, we're at the non-urgent moves, the bread and butter. This is what we do on a regular basis. These are going to be the patients that you move 95% of the time. The patient is stable, there's no clear threat to you, your partner, or your patient, and where they are, the patient can be fully assessed and possibly treated before we even start moving them. We don't necessarily need to complete our assessment and treatment before we move them, but it is something that we have the option, the ability to do. We are also taking into consideration that moving them quickly or rapidly might cause us to aggravate an existing condition or make their chief complaint or what's bothering them the most more severe or worse. When we are dealing with moving these patients, we have a lot of commercial devices as well as specifically approved methods of moving patients, and we're going to go into all that. We'll start with the patient carrying devices. The most common patient carrying device is known as a stretcher, or where I work and where we are learning, it's known as a gurney. So you'll hear stretcher, gurney, cot, striker, which is a copyright trademark name, the Furno, which again is a copyright or trademark name, and same thing with devices like the stair chair. These stretchers, these wheeled devices, can be powered, unpowered, or manual, and they may be specifically designed for transport of specific patients, like bariatric stretchers, or our isolette or neonatal transport units with the incubator attached. So these devices are very specialized. And depending on where you work, you may see multiple different styles of gurney or stretcher. And you'll see that depending on where you work, it usually will sway towards a very specific type or model because most areas are serviced by sales representatives. And where I work and where I teach, 99%, so the vast majority is going to be serviced by strikers. So we'll see the Power Pro or the striker models. Other areas may use Furnos of different ages, and there are a couple other manufacturers, but really the two big hitters are Striker and Furno. Striker and Furno. What you're seeing here is a striker. This is a Power Pro XT, and you can see that below the provider that's at the foot of the patient, you can see that there is a large device below his left hand. That's a battery pack. These battery packs allow the device to go up and down using oil and pneumatic pumps. This ambulance that the patient is being loaded into will still need to be manually loaded, so the provider at the foot end will need to hold the gurney in place while the legs retract, but it should be no more than 5 seconds for the legs to go up fully. And if for some reason the battery dies or they have some type of malfunction with the electrical components, the gurney can be changed over into manual override and can be manually lifted and lowered so that we can move our patient in and out of the ambulance and in and out of the hospital or receiving facility. On the left, we have the power stretcher. This is made by Furno. On the right, we have the Power Pro or the Power Pro XT, which is made by Striker. There are a lot of variations that you'll see, and we'll talk about them more specifically when we get into the chapters, such as the neonatal isolettes or the neonatal incubators. We'll also be talking about the different styles that you may see in air operations because these gurneys are very large. They are meant specifically for ground transport. The type of gurneys that we'll see for air transport are typically much smaller, made out of a aluminum or aluminum alloy frame, and will not look nearly as impressive because they don't need to go that far. They typically are able to land at the patient's side or have the patient brought to them. And from the helicopter or fixed wing aircraft, they go directly into the ER or onto a waiting ground unit. This is an example of the Striker manual gurney that is designed for bariatric patients. Bariatric patients can be specific to weight or circumference, their overall size, but these gurneys are set up with very specific attachments. They have different places to install poles, like you see the providers at the head and feet of the patient holding. They can also use tank tread style fold-up ramps, or they could even use an installed winch unit. Because we have an increased understanding and increased load of volume for obese or overweight patients, many services have at least one bariatric unit so that they can take patients that are larger than what our normal ambulances would be able to comfortably carry. And typically, these ambulances are reserved for interfacility transport, or IFT. These are non-emergency patients. If a patient is an emergency, in some type of an emergency, and they are stable enough, we can always ask for a deployment of one of these vehicles, but rarely is that going to be the case if the patient is having a true medical or traumatic-based emergency. Other carrying devices that we may have on our ambulance, depending on where you work, are items like a stair chair, which is a chair with either handles that extend from the front and back, as well as the possible addition of a tank tread on the back so they can be lowered down the stairs. Or in the event that we don't have that attachment, the patient would end up being carried down manually by the providers. And then we have our other patient carrying devices, like our spine board, both short and long. The short being used specifically for securing the majority of the spinal column as well as the entirety of the cervical spine, while using straps to keep them from moving and allowing us to effectively get them out of the vehicle or out of the enclosed space, and then transfer over to a long board. the longboard being the most prominent and most commonly used patient carrying devices that are for full immobilization. This is an example of a striker stair chair. You can see it's very difficult to imagine carrying a patient down the stairs, and this device actually has the tank treads on the back, which extend and allow the provider in the back to slowly control the descent of the patient by use of those tank treads. There's still the handles in the front so that another person can guide that stair chair down the stairs. And if the stairs really aren't meant for the tank treads, if we're in a really, really nice home with beautiful carpet or a historical landmark, or if the stairs are too broken or unkempt, then we can go ahead and we can lift them up directly. So it's an option. Our short spine boards are one of our least used, at least locally, instances of the spine board. This is used specifically for very short periods of time for our patient to be secured and removed from wherever they are and placed on either a long backboard or placed in a position where we can employ the spinal motion restriction or SMR concepts that we talked about a little bit earlier. In the area that I work in, short spine boards, while carried on the ambulance, are very rarely used. We are more likely to use the Kendrick's Extrication device, which is a copyright and trademark device, and we'll go into that a little bit later, but even that is used very, very rarely. A long spine board is what the majority of EMTs have some type of mental connection to. This is what we see at pools, in first aid offices, at your school, in popular culture. Everyone has seen one of these boards before, and they come in many different styles. I would say shapes and styles, but really it's all the same general shape, and the style really changes based on the color, the markings, and the way that they have the ability to strap our patient in, which we'll talk about more in a little while. Not today, but in a couple of our future. So what we've already been talking about are some of the more common aspects of ways to get patients moved around, but some of our less common but equally important devices are the ones that we see typically either on the engine or and by engine I mean on the fire engine or on the truck, or what we see more commonly stowed off to the side alongside our backboards, such as our portable stretchers, our scoops, our baskets, our breakaway stretchers, flexible stretchers, vacuum mattresses, and one of the newer additions, our Mega Mover. So we're going to talk about those right now. Now, the very first one that I want to talk about is the patient immobilizing device. We've talked about the vest type extrication device, but really this is going to be known most commonly as the KED. KED is short for Kendrick Extrication device. It's a copyrighted item, and it's used specifically for patients that need to be immobilized that are already in a seated position. This is best utilized for patients that are in a vehicle that needs spinal immobilization, but because of an extended extrication, we have to cut them out of the car or whatever the case may be, we can go ahead and place them in some type of immobilization in the meantime. This device is also really good if we need to get a patient out of a small space. So just recently, it's the 25th of August, a few days ago, there was an article that came out about an individual that unfortunately did not survive the event, but found themselves crawling into and becoming stuck inside of a pipe in a water park. Now, this individual that was stuck in the pipe in the water park likely incurred some type of injuries when they fell in. People don't normally get stuck inside of confined spaces without incurring some kind of injury, or at the very least becoming impinged to the point where we're concerned that they may have some type of an injury. Now, it's not very clear. There's a lot of information I don't have, but in a case like that where a patient may be in a seated or lying position, we can utilize a device like this so that we can immobilize the entirety of the spinal column, or the parts that we can actually manipulate, so the lumbar, sacral, thoracic, and cervical spine, and then we can extricate them. There's going to be a supplemental video on the application and not the application itself, but the application and successful implementation of this device, and I'll also be linking up some non-channel videos that would be good reference points for you to go and check out. But these devices, in my own personal opinion, are very underutilized in the system that I have worked in, as well as the systems that I have worked around. The KED is one of those really specific tools that frankly is underutilized because we just don't use it enough. Some departments, on the other hand, use this device all the time, so it really is hit or miss. It's not something that's necessarily going to be a device that you never ever use, but in my experience, and I've worked in the majority of the different geologic and geographic areas of the county that I teach in, that we don't really use it. It doesn't matter if we're on the north or south end, east or west, or somewhere in central. So, but that's more just a result of training being very consolidated to a couple of very specific schools. And my goal, as always, is to bring as much of the educational opportunities to my students so that they can start to implement it themselves. And who knows, maybe in 10 years, they'll start to use the KED more often because they just heard it from crazy Mr. Johnson that this is something that we don't use. And they thought, well, shoot, I don't know. I mean, maybe we'll pull it out. We'll throw it on the patient. A less common device in this area, but certainly a very popular device in other parts of the country, is known as a scoop stretcher. This scoop stretcher is developed and built by Furno, and it is exactly as it looks. Those pieces split in the middle, and you can scoop your patient and take them and put them on the gurney. Now, this is a piece of equipment that I very rarely see when I'm out in the field, and it is one that I have very little professional experience using, but I've spoken to individuals that have used them, and the feeling is mixed. Some people really like them, some people really don't. I only see an issue because there is a massive void in the center of the scoop. And if you're looking at it, you're probably thinking, won't that put a lot of extra pressure on the spinal column? You're right, nobody. That's exactly my problem with it as well. It puts a lot of undue pressure on the spinal column. So this is something we cannot use if we have any suspicion of spinal injury or any patient history of spinal stenosis, kyphosis, or really any spinal injury. So it's very limited in how we can use it. But there is a better device, and I'm going to talk about it in just a little bit. This patient carrying device is known as a basket stretcher, and sometimes it is referred to as a Stokes basket. What we're really talking about is the same thing. A basket stretcher is typically only utilized in situations where search and rescue crews are involved or where fire and rescue crews are involved. The reason? This is bulky. It's bulky, but it has purpose for being bulky. Why? Well, this is really good for lifting patients or hoisting them out using high-angle rescue or using a lift winch on a helicopter. It's also really good if we need to carry them out by long distance, or in snowy situations, we can use it as a modified sled. It's not as good as the sleds that you may see up on the mountain in a professional ski rescue situation, but they are not bad in a pinch. These are more common with, again, with rescue services, and because they're so bulky, most of our ambulances don't have a good location for them. Where I work, there are no private agencies that carry these until you get out into the far stretches of the desert. So this is a very agency or approach specific type of equipment. When I say agency or approach specific, I mean you're normally going to see them only with the fire department or rescue personnel. This is a flexible stretcher. Now, this flexible stretcher looks a little bit closer to that scoop, but at the same time, it kind of looks almost like an old traditional stretcher that you used to see in movies from way, way, way back when. And you would be right. This stretcher is very limited. It can bend in the upper 3/4 or the center of the device, meaning that you can either sit your patient straight up or they can lay flat. So it is a little bit less effective than the device we're about to be introduced to, but these flexible stretchers are something that you'll see out and about. There are some services where I teach, so this is for my students, you may see these. Just understand that our biggest concern with these is always going to be the hinge, the pinch point. We don't want to pinch our patient, especially if our patient has very fragile skin. I mean, you don't want to pinch your patient in general, but especially if they've got fragile skin or they're on blood thinners. So these are not exactly ideal. These are not my favorite. These, however, the breakaway flat, I like these. Now you can see that the hinge, it's a little bit difficult to see, but it's in the upper half, the upper third of the device, which means that this can sit directly on top of the mattress of your gurney or stretcher, and you can go ahead and you can undo the hinge and you can sit your patient up in the semi-Fowler's position. The only thing you won't be able to use is a knee gatch, so they'll have to lay with their feet flat. Another really nice component of this is the fact that, unlike our scoop stretcher, this has a rigid plastic spine that runs up the center. That's why it looks so funny in the middle. It's not just a design, for aesthetics type of issue. What you're seeing is a plastic spine that's interwoven with material, heavy-duty material, that is throughout the entire device. And then the outer part, the orange part, that's made out of a leather substitute, like a pleather, plastic leather. This device allows you to effectively log roll your patient on, move them to your gurney, unlock the locking mechanism so that they can sit upright or in a semi-Fowler's or slightly reclined position. And when you decide to move them over, you can lay them down flat, lock the flat, move them over to the new bed or wherever they're going, and then by pulling out that plastic ridge, both left and right sides come completely apart. And now you can pull everything out and it's independent, hence breakaway flat. I was not a big fan of these when I started working here locally, but over time, over about a six to 8 month period, I realized how versatile they are. And I realized why many of the departments that work locally require that their ambulance services that respond to 911 calls carry these on their gurney, not just in their ambulance, but on their gurney. They're wonderful tools. If you're working for a service that has these and you don't normally use it, I'd like to recommend that you change it up a little bit. Try a couple shifts with this on the gurney. I guarantee this is going to be a game changer for you because you won't have to depend on flimsy sheets anymore, and you definitely won't have to do the awkward, well, I'll take an arm and a leg and you take an arm and a leg, or maybe we can convince them to scoot over. This is so much easier. So I have nothing but good things to say about the breakaway flat. Really, the only downside is when it starts to degrade. And at that point, these devices are not wildly expensive. They're very reasonable. And for your services, they'll last many years. So it's easy enough to fix or to replace them instead of fix them. So I would highly recommend that if you haven't already and you're in the field, give this one a shot. Now, one that we don't see very often, at least in my area, are the vacuum mattresses. Now, there's a very good reason for this. The vacuum mattresses are relatively new, they're very expensive, and per most of the recommendations of the manufacturers, they are not reusable. Now, that is something that can be played fast and loose with, but at the same time, we really have to go by the recommendations of the manufacturers. So we don't want to misuse it, but these are very nice in theory because they can have all the air sucked out of them and then they conform to the specific shape and size of your patient. These are used very well in conjunction with a blackboard or some type of rigid or non-conforming device to extricate the patient. So we can use a backboard, we could use a Stokes or basket stretcher. We could even put them directly on a flat. It's all about patient comfort. So this is a great device in theory, but again, they're fairly new and more expensive than most agencies are willing to spend. Finally, we have our medical mover or the mega mover. Now, don't let the name don't let the name confuse you with the picture. The actual device is very large. It is anywhere from 8 to 10 feet wide and typically 10 to 12 feet long. It also comes with reinforced straps along the entirety of both sides, as well as at the head and feet, and can be used universally. Again, just like that vacuum splint, this is technically one-time use, and they typically have a weight limit of anywhere between 400 to 700 pounds. Hence the need for all of those extra handles. These are great devices if your patient has absolutely no concern if we don't have any concern for a patient having some type of spinal injury or concern for spinal immobilization, as well as the ability to be carried on something that is basically a glorified sheet. But these are great devices to have on your gurney or at the ready, because if your patient is not ready to be moved, or has urinated or soiled themselves, or maybe has vomited or rolled around in some blood, as long as we're not suspecting trauma, especially with those patients that are covered in blood, as long as we're not suspecting trauma, this is a fantastic way for you to move your patient, get them onto the gurney, and limit almost entirely your exposure to their fluids. Now, what do you think is going to be the most appropriate patient carrying device for the majority of your calls? Go ahead and comment down below. If you're already working in the field, tell us what you like, what you don't like. And if you're one of my students, we're going to talk about this in class. So take just a few moments to think about it, and we'll come back right after this. All right. We've talked about all these different devices. We've talked about the pros, the cons, why we use them, when we use them, so on and so forth. But the real question is, how do we get them onto some of these devices? They don't exactly look like they're that difficult, but you have to think about your patient disposition. If we need to carry them somewhere, there is likely a good reason, medically or because of inability. They're handicapped to the point where they cannot do that thing. And by handicapped, what I am specifically referring to is they are injured and they have lost a specific ability. So, how do we get patients onto these devices? It depends on the disposition, how the patient looks, what we are starting to suspect. So we'll start with the most important and really the most difficult patients to move. Our patients with a suspected spinal injury. Before we move any patient with a suspected spinal injury, and this could be based on their complaint, it could be based on observation or palpation where we put our hands on our patient, or it could be based on injury due to mechanism. If you were to be struck by a vehicle at really any speed and knocked over, most agencies, most counties would say that is trauma by mechanism. And so we have to suspect, if you've been hit by a car, that there's a decent chance that you sustained a spinal injury until we can rule it out. But there are a lot of different permutations on how that works. What you need to know right now, because again, this is only our very earliest chapters, is that any patient that has a suspected spinal injury needs to have their head and neck immobilized. We need to immobilize the head and neck primarily. The spine, the majority of the spine being the thoracic and lumbar section, oh man, I can't talk today. The thoracic and lumbar sections will need to be immobilized based on your local agency's protocols. But really what we want to do is we want to try to limit as much movement as possible. So before we do anything, we're going to provide and perform a maneuver called manual stabilization, which we'll discuss later on in class. But basically, we're going to hold the head and neck in place. After manual stabilization is done, we will then either perform our head-to-toe assessment and visualize and palpate the neck and spine, and then apply a rigid cervical collar, or if we're anticipating an urgent move or an emergency move, if we have time, we'll place a rigid cervical collar. And really, by definition, we're not going to have time for an emergency move to place a rigid cervical collar. And I'm happy to debate that. I know that there's a lot of people who say, oh, Eric, there's totally lots of situations, so you got your car, and they're going to have a million different things that they want to say. But at the end of the day, if it's an emergency move, there's really no time to do anything besides get them away from the dangerous situation. But regardless, we've got our rigid cervical collar, and now we are going to continue to hold manual stabilization, even though the collar is in place, until they have been at least temporarily immobilized on the spine board. And again, that can change based on where you work. But how do we get them onto the board? Well, we're going to utilize a method called log rolling. Log rolling is when we have our hands across the patient's side and we roll in unison so that the head, neck, and back all travel at the same time. And by extension, we're also maintaining spinal integrity by not rotating the hips or moving the legs faster than the rest of the body. It's a very easy maneuver to talk about in concept, but it does take practice to make sure that it happens in real life. If we have a patient that we don't suspect has a spinal injury, they just have a run-of-the-mill medical aid, or even if it's trauma, there's no spinal injury suspected, we can use an extremity lift, also known as the Georgia Straight, where we have one provider under the armpits with their arms wrapped around the front, grasping the patient's wrists, and the other provider under the bend in the knee. Now, this maneuver is something that we're going to be talking about in a little bit, and we can also utilize other tools that we have, such as sheets, mega movers, or other devices to get them from A to B. But as with everything in what we do, there are pros and cons to all these methods. The extremity carry, also known as Georgia Street, looks just like this. You can see that the provider in the rear has their arms, and real frankly, they're not really close enough because there's a lot of space in between the patient, their center of gravity and weight, and the patient. So there's a lot of weight that's being pulled down on the lower parts of the provider's back on the left. On the other hand, our provider that is on the front, holding the legs, seems to be adequately positioned. She doesn't look like she's holding weight in an uncomfortable or improper position. The Georgia Street, or GS maneuver, is great if we have a patient that's relatively young, doesn't have any underlying conditions, we're not concerned about massive trauma, and isn't at risk for getting us all covered in the nasty wet stuff that we don't like, i.e. blood, vomit, urine, feces, anything that really we don't want on us. It's also important to remember that those are the things that we can see and feel, and I mean, hopefully, but I suppose I should say it, taste. Ugh. But we also have to think about the things that this patient is now leaving on our uniforms, which we transfer onto the seat belt and onto the seat of our ambulance. So we really want to try to minimize the amount of contact that we come into the patient with as much as possible. Also, the GS maneuver is great in theory until you think about the kind of pressure that you would be putting on the armpits and shoulders of your patient, as well as the type of pressure you may put on their hips and the inside of their legs and knees by carrying like this. It's great in theory until you're dealing with a 95-year-old patient with very fragile skin and blood thinners. And now we're starting to get into situations where we could potentially do significant amounts of damage to their musculature and soft tissue, and in some extreme cases, even to their joints and bony structures. So we just need to be really careful about moving them around like this. If we have patients that don't have the suspected spinal injury and we don't want to use the Georgia Straight, we could always use a direct ground lift where we can pick them up directly using articles of their clothing, or we can also utilize their own ability to help scoot over onto a device or onto a sheet. Once we have them on a sheet or another device, we can use the draw sheet method, and to get to there, we have the log roll method as well. Draw sheet means that we have a sheet or a blanket or a mega mover underneath the patient, and if they're able to help us, we can have them scoot over, or if they're unconscious, unresponsive, or unable, we can log roll them using multiple providers. We can use that opportunity to look at their back and palpate and feel around, and then we can roll them back onto the sheet. So what this looks like is pretty simple. You have two providers that are dealing with a patient that's on a sheet. You can see that they're going to roll the sheet up, and they're going to basically pull the patient towards them. This is good in theory, but it doesn't really match what we do in the real world. Typically, we'll have another provider on the other side that will help control the motion, so the person that is pulling is doing the majority of the work, and the person on the other side is making sure that our patient doesn't roll off the sheet. Worst case scenario, they roll off the sheet and off the bed, in between the bed and the gurney, which is really bad. Less likely, but still bad, is we get our patient, we start pulling them, and they come off the sheet completely. Now we have to redo and start over, and that's kind of a pain in the and it's difficult for our patients. Now, what you didn't see is the process of moving them over from the hospital bed onto the gurney. But if you follow along with the supplemental video that I've got linked in Canvas, you can go ahead and see what the members of the Castle Rock Fire Department use to get their patients from the floor to the gurney and from the gurney to the bed. We also have other positions that we want to talk about specifically in this chapter and how we can position them. The most specific is the recovery position. A patient placed in the recovery position will be best positioned that way if they're at risk for aspiration or vomiting. If our patient is going to vomit, they run the risk of aspiration. And aspiration is a vocab term that we haven't quite gotten to yet. But basically, it means that we have fluid that is somehow getting into the airway of our patient. If you think of a fountain and you think about the flow of fluid from a fountain, it goes up and then back down. When our patients vomit, they do the same thing. Unfortunately, it's not a big, beautiful display of awesome water tricks and whatnot. It's a mess, and now our patient is at high risk for choking on that same material. The left lateral position puts the patient in a better position for hemodynamic activity, so their heart is going to be less taxed, and their body is in a ideal position if they do vomit. This is good for patients that are less than responsive or are saying the almighty terms of I feel like I'm going to throw up or I'm feeling nauseous. What this doesn't work for are for patients that are in full spinal immobilization techniques. However, if they are appropriately applied to the spine board, to that backboard, we can roll them onto the left-hand side if they do say that they're nauseous or begin to vomit. Another reason why the left lateral recumbent position is effective is because, again, we're helping the patient's heart work just a little less hard to move blood around. However, if we're dealing with a patient that's in shock, which again is another term we haven't gotten into yet, we want to make sure that we don't elevate the legs or elevate the head. We want to try to keep them in a position that is nearly supine or nearly laying flat. We'll discuss shock more in future chapters and very soon, as a matter of fact, but what you need to know for shock right now is that the body tissue is not being effectively infused or perfused with oxygen. Again, shock is a state of insufficient perfusion. Now, we've talked about dealing with getting our patients out of confined spaces, cars that need to be cut into to get them out, from the ground, from other beds, from upstairs, downstairs, from remote locations using a Stokes or a basket stretcher. We've talked about a lot of these different scenarios. What we haven't really spent any time talking about is transferring that patient from your gurney or stretcher to the hospital bed or stretcher. So when you arrive at the hospital, you're going to have to get them off of your gurney. You can't just say, all right, well, hop up. We're here. Taxi ride's over. That'll be $1,700. It doesn't work like that. We have to move them over just like we had to get them over in the first place. How do we do that? We're going to use the exact same method that we talked about in reverse, from the hospital bed to the gurney, now from our gurney to the hospital bed. We should have at least 2 providers doing this. You should never move a patient alone, and we should never move a patient from gurney to bed alone. I don't care how strong you are or how small they are, don't do it. This is how you end up losing your job and getting sued. You can see that the patient here is on the gurney, and we're going to have to assume that they have some type of a sheet that can support the patient's weight underneath. We have 4 providers here, 2 from the hospital and 2 from the ambulance. This is ideal because we'll have plenty of extra muscle and we'll have plenty of dispersion of hands on sheet. Now that you see we're ready to move over, they're using good communication, eye contact, and verbal communication in conjunction to figure out how to get them over. So they'll all grab, count to 3, say, all right, we're going to lift on 3, 1, 2, 3, and then move on over. You can see here, again, we have those fine points of effective communication. The providers are looking at the clinical staff, our nurses, our ER techs, our doctors, and the the clinical staff are looking back at our EMTs and paramedics. And just like that, we pull them over to the other side of the bed. It really is that simple. Now, it may look like there's a lot of steps that we've missed, and that's why I'll be adding some supplemental videos to make sure that you're very, very comfortable with how all of this works. So we're on our last slide. Now, before we go, I want you to think about a couple of things. First and foremost, why are body mechanics so important when lifting and moving patients? And I don't want you to just think about the patient safety, but also about the safety of you and your partner. Because as we discussed in other chapters, safety is priority number one. Every single call, safety is always the most important aspect of what we do. Next, why is using the appropriate patient carrying device an important consideration? And so that we can start preparing for the eventualities of being very flexible and using critical thinking skills in the field, when can we use a device for a non-traditional use? What are some scenarios that you can come up with where a device like a breakaway flat would be just as good as a Stokes basket, or when a stair chair would be just as good as using the Georgia Street method for moving a patient? Next, when would an emergency move be necessary? This should be very, very simple. We shouldn't overthink this because, again, the emergency move is the one that we will do the least of all. And finally, in what ways can proper positioning help improve or maintain your patient's condition? I want you to go ahead and answer below. If you're in my class, be sure to bring these up in class or be ready to bring these up in class because I will be asking when we meet for our Chapter 3 Zoom lecture. And if you are simply observing from the outside, or if you're already a provider at any level, first responder, EMT, advanced EMT, paramedic, even at the clinician level, if I've got any doctors and nurses out there, I would love to get your feedback on this. So please leave a comment down below and be sure to be very specific about which question you're answering. Or if you're an overachiever, go ahead and answer all 4. But that pretty much does it for today. Again, this was the Chapter 3 review for the Emergency Care Textbook for EMT. And as always, I'm your guy, Eric Johnson, the Band-Aid Man OC himself. Thank you very much for stopping by. Have a great one. We'll see you again soon.